Hey everyone, my name is Nimrod Disyachjeli, Chief GI Fellow at the University of Wisconsin. It is my pleasure to be here with Dr. Mark Benson, Section Chief of Advanced Endoscopy at the University of Wisconsin, to talk about his recently published article in GIE titled The Top 10 Tips for Managing Iatrogenic Colon Perforations. Thank you so much for joining me today, Mark Benson. This was a really well done article, very informative, very easy to read. Can you just share with me a little bit about the inspiration for writing an article like this?
Sure, thank you very much, Nimrod. So, I'd given a talk about colon perforations 2 years ago at DDW. And during that talk, I mentioned the endoscopic repair of those perforations. And so in the wake of that, I received several emails from people across the country asking me follow-up questions. So it made me realize that there was an interest in this.
Great. I'm definitely on the receiving end of that interest because this was very informative. As a trainee, I'm always trying to optimize my technique, but even seasoned endoscopists can use some technique tips. During colonoscopy, what should providers do to minimize the risk of colonic perforation?
So clearly, you want to avoid the maneuvers that are associated with perforations. You don't want to introduce large loops. You don't want to introduce the scope when there's fixed resistance. And you want to be careful when taking off large polyps. There are ASGE courses on how to remove large polyps and endoscopic mucosal resection, and I would encourage viewers to attend those because I find that they're very educational and they lead to improved outcomes and improved patient care. Remember, these are often elective procedures. You don't have to get to the cecum. You don't have to take off that polyp, and people should be reminded of that. And then lastly, recognize that this is a quality metric. So our overall perforation rates for our colonoscopies should be less than 1 in 500. And if your rate is higher than that, or one of your colleagues' rates, say it's 1%, I would argue that they should be retrained on how to do colonoscopy, or should give up the procedure altogether.
Wow. We're always striving for quality in our department, and some of those courses sound really interesting. In your experience, how often have you had to repair colonic perforations?
Well, fortunately, as a busy endoscopist, like most busy endoscopists, I haven't had many perforations in my career. But the most recent one I did have was a large cecal polyp that was referred to us. And it had been biopsied extensively, and somebody had placed a tattoo at the actual polyp, which you want to avoid and you don't need to do because it's the cecum. And it was a difficult resection, and at some point I recognized that there was a perforation after grabbing some tissue, and that's a stressful episode for a provider. But the patient was stable and the prep was excellent. So I was able to close that perforation just with through the scope clips. I got them admitted, I got them on antibiotics, I consulted surgery, and they did just fine clinically.
Great. I'm glad it worked out for that patient. I think I can definitely share that same experience of fear in the exact moment when a peri-procedural complication occurs. But the next thing after fear is to figure out what to do next. So can you help us figure out exactly who should be closing these perforations and which patient should instead be sent to surgery?
Yeah, so you want to make sure that, first of all, that you yourself are very calm. Mm-hmm. You want to make sure that the patient is clinically stable without signs of an acute abdomen, with stable vital signs, without signs of clinical deterioration. You want to make sure that the bowel prep is excellent. If there is a poor prep and there's a perforation, the person is at higher risk for feculent peritonitis and poor clinical outcomes. But based on the size of the perforation and the location and your scope position, if it seems like it's appropriate, then I would recommend that people try to repair these. But you do want to avoid suboptimal attempts at repairs if the person does not have the right skill set or the right equipment, because that leads to worse clinical outcomes.
I guess this, as they say in the poker world, you got to know when to hold them, got to know when to fold them. Last question, Dr. Benson. Does it work? Can endoscopists really close these up?
It does work, especially for perforations that are smaller than 2 centimeters. Those you can usually close 90% of the time with either through the scope clips or over the scope clips. Perforations that are larger than that or larger than 3 centimeters, There are often specialized techniques to seal those perforations, but that's usually a really specific patient population in a specific setting, and I would say that most of those larger perforations should probably go to surgery.
Wow. This was really fun. Thanks for spending time with me today, Dr. Benson. You'll be able to see this video online with the published manuscript on the GIE website. Your contact information, including email, should also be available there. And yeah, thanks again for sharing your wisdom with us today.
Thank you very much.